Today we will be looking at microcystic adnexal carcinoma. It is also known as sclerosing sweat duct carcinoma or malignant syringoma, and it affects adult patients over a wide age range with an equal sex distribution. Clinical features include firm indurated plaque, nodule or cyst-like lesions, which are often skin-colored or yellow, ill-defined with telangiectasia. It is usually smooth, but occasionally can be atrophic, scaly or fissured. The average size is around 2 centimeters but can range from 0.03 to 17 centimeters squared, and it often affects the central face, especially perioral and periocular areas. So this is a picture of a patient with a MAC undergoing Mohs surgery, and you can see how extensive the disease is compared to the clinical appearance. In terms of etiology, it is thought to be related to radiation therapy, ultraviolet exposure, and follicular differentiation. And imaging, such as MRI, may be needed if you are looking at tumor size and metastasis. In terms of histopathology, there is an infiltrative growth pattern with extension beyond the dermis into the subcutis. There are strands, cords, or cysts of epithelial tumor cells embedded in sclerotic stroma. And there is often the presence of zonation, in which you have keratosis in superficial dermis, strands and cords of tumor cells in the mid-dermis, and duct-like structures in the deep dermis and subcutis. There can be perineural invasion, and EMA, CEA, CD15, and CK7 are positive. So this is the histopathology showing small jagged islands of epithelioid tumor cells embedded in a sclerotic stroma with occasional small ducts and horn cysts, as well as peripheral lymphoid aggregates. And this is a picture showing perineural invasion. Differential diagnoses are Monfier-form BCC, desmoplastic trichoepithelioma, as well as syringoma. In terms of the clinical cause and prognosis, this is a slow-growing, locally aggressive tumor, and metastases are rare. Treatment, surgical excision, Mohs surgery, especially if you have recurrent or periocular disease, which may require slow Mohs or excision with review of paraffin sections for better visualization of the cells. Radiation therapy can be offered for patients who are poor surgical candidates. And for metastatic disease, you can offer cetuximab, cisplatin, paclitaxel, sorafenib, and in advanced disease, you can consider imatinib. So in a suspected lesion, you need to go through this algorithm in which first you do a complete skin examination and node examination, and then you biopsy the area. If it is indeterminate, you may need to re-biopsy, or if it's inconclusive, you may have to do the stains such as CAA or EMA, CK20, BER EP4 with or without CK17. When the diagnosis of a MAC is confirmed, you should consider the need for imaging, either CT or MRI. You may require fat suppression MRI protocol for PNI or intraorbital tumors. Risk factors include intracranial extension and whether it's node positive or metastatic. For local disease, consider Mohs surgery, wide local excision with 2 centimeter margins, or radiotherapy if the patient is not eligible for surgery. For patients with nodal disease, they will require surgery for local disease as well as excision of the involved lymph node. For patients with metastasis, you need to consult with oncology. For resistant disease, consider clinical trials or experimental targeted therapy. So for follow-up, you need to do history and physical examination every 6 to 12 months for 5 years, looking at the skin and lymph nodes. Teach the patient how to do self-examination and consider periodic ultrasound of the nodal basin for sentinel lymph node positivity or those thought to be at high risk for nodal disease. If you have no recurrence, continue to follow as clinically indicated. For patients with recurrence for local disease, consider Mohs with or without RT. For nodal or distant metastasis, surgery and multidisciplinary tumor board would be required. And with that, I thank you.